Today's topic is self-management of hepatic encephalopathy, and it's an important topic because we have to understand the intricacies that are associated with the self-management. So the brief outline would be the disease burden, especially the covert HE, which is the main issue as far as the self-management is concerned. Identifying the need that why we actually require a self-management or a strong self-management protocol. Effect of HE on the patient, it affects the cognitive, verbal fluency as well as the sleep. We'll also discuss about the effect of HE on caregivers, how to diagnose covert HE, the treatment, and how we are moving ahead with remote monitoring and wearable devices. So as far as the cirrhosis is concerned, it's not an old age disease. That is the most important thing to understand. Where in this Lancet publication, they have shown that most of the mortality they peak at around 50 years. And the patients of cirrhosis, they die at a much earlier age as compared to those with diabetes, cancer, or other malignancies, especially in the age group of 30 to 50. And the self-management should include activities related to the medical management as well as the emotional management, problem-solving, decision-making, and social support. The overall global burden of cirrhosis is high, with the daily estimated loss of the daily estimate is around 41.4 million, and it's a very prevalent disease with decompensated cirrhosis of around 10.2. So how cirrhosis and HE, the burden is concerned, the incidence of HE is around 11.6 per 100 patient year. Prevalence of covert HE or CHE has been reported to 30 to 85% of cirrhotic patients whenever they are tested. The overt HE estimate occurs at around 30 to 50% of cirrhosis with an annual risk of development in around 20%. And alcohol-related cirrhosis and presence of portal hypertension, they have higher association. So identifying the opportunities of HE self-management, the first study by Walk published in American Journal of Gastro, where an intervention questionnaire was done for a patient of 150, median age of 57. Overt HE was seen in 23%, with most of the proportion of patient with CTP A and B. At baseline, what they found that only 56% of the patient, they understood how to titrate the dose of lactulose. Only 12% knew that they have to eat a high protein diet, and 44% they had this idea that they have to avoid unsafe over-the-counter medication. Another study where a retrospective cohort of patient was studied who had attended the emergency or were hospitalized for HE. All these patients, 100% of these patients had hepatic encaph at presentation, but within 30 days of discharge, only 36% of these patients, they actually came for their refilling of their treatment for HE. And the adherence of medication, that is more than 80% adherence, was seen in only 16% at the end of 3 months and 10% at the end of 6 months. This study by Dr. Praveen Sharma, where a cross-sectional 21-item survey-based study was there of 251 patients. Higher proportion of patients were in the CTP B and C, and they found that only the nutritional targets that could be met by most of the patients for calorie and protein intake were less. Another study where the patients were again questionnaire based, 34% they were unsure that they had decompensation at presentation. 14% they were unsure if HE was a part of decompensation, and any uncertainty for decompensation in these patients had a lower health related quality of life. Then a few more studies where the caregivers were also, care partners were also assessed, and it was seen that the patient were aware of HE history based on the SF36 questionnaire, and the awareness of caregiver was seen in only 48% in patients who had a history of HE. They knew that 6% of these caregivers, they knew that how to manage the treatment for HE and what could be the side effect. In this study published in 2019 by Jasmohan Bajaj, and they also selected those patients who were discharged, who were admitted for non-elective reasons, that is reasons not related pertaining to HE, but within 90 days of discharge, what they found that HE caused the admission or diagnosis during hospitalization, but 272 patients were not on HE treatment on follow-up. This is also, there is a effect on the quality of life even in those patients who are on liver transplant list, where it was seen that patients of more than MELD sodium of more than 20, they have significant impairment of the health-related quality of life that affects the anxiety, fear component, depression, fatigue, and physical impairment. And HE was the strongest predictor for the impairment of the health-related quality of life in these set of patients. It is also important to understand that HE is one of the important reasons for readmission in cirrhosis, where in 2016, Dr. Bajaj, in 1,013 patients, they found that readmission rate at 3 months was 53%, and majority of these patients were readmitted for HE, and the infants that higher MELD and prior history of HE were the main reason for readmission. Another study where a 28-day readmission was assessed, it was seen that 31% of these patients were readmitted, and HE was the strongest factor. And even at 6 months, it was seen that in another study by Rui Gasper, where they found that readmission rate was nearly up to 60% with HE as the most important factor. Then how it affects the caregivers? In 2011, 104 patients of cirrhosis and their caregivers were assessed. Caregivers were assessed based on the patient care burden questionnaire. And it was seen that patients who had HE, the effect of HE, previous episode, if there is a previous episode, these caregivers also had a worse outcome as far as their unemployment is concerned, their financial support, and the burden is concerned. And this was seen even in higher in proportion of patients who were having impairment as far as the speaking or ability of walking is concerned. This study of a cohort of 541 patients, it was seen that the social support and risk of mortality is also associated, were more frequent, and these components were more frequent in individuals who had cirrhosis as compared to comparators, that is the low social support, loneliness, and higher proportion of patients were living alone. And this was also correlating with the mortality risk seen in these set of patients. So how HE affects the patient? It may affect the cognitive impairment, a verbal fluency, as well as sleep. The memory impairment is seen in patients where the memory status was assessed by the Wechsler memory scale. Around 22% of these patients, they had grade 1 HE, but when they were assessed for the cognitive impairment, it was seen that nearly up to 92% of these patients who were having cirrhosis without any prior history of HE, they had cognitive impairment. And those patients who had HE, this decrement was seen in up to 100% of the patient. Then other effects that is seen in covert HE includes the cognitive reserve, which is proportionately less in patients who had covert HE. This cognitive reserve was based on the Barona index, which is a questionnaire, which is also based on the Wechsler memory scale. And in these patients, 118 patients who were assessed, none of these patients had overt HE. 49% of these patients, when assessed based on the PHES, they had covert HE. And they were also assessed for health-related quality of life, psychosocial score, cognitive reserve, and the sickness impact profile. And these patients were found to have lower cognitive reserve. They had a poor health-related quality of life, and these factors were independent of their MELD status. It also affects that increased risk of hospitalization, where patients with 170 patients where covert HE was seen in 56% of the patient, and the progression from covert to overt HE was seen in 30%. These patients had higher hospitalization, and increased proportion of patients had mortality within 6 months. Unsafe driving is another important factor that we need to understand as far as the overall caregiving burden for a cirrhosis patient is concerned, where 205 patients were assessed. MHE based on PHES score was diagnosed in 48%, and 163 patients of these 48%, 163 of the total proportion, they took the driving simulation test, and they found that most of these patients, higher proportion of these patients, had unsafe driving in the terms of taking a wrong turn or unable to negotiate small driving skills. Then another important factor that gets affected when patient of cirrhosis with CHE is concerned is their slow speech, where the speech was assessed in this study published in American Journal of Gastro. And they found that the 3 important features of speech, that is the speech rate, word duration, and use of particles, they were significantly less as compared to those patients who were not having overt HE. It also affects the sleep in cirrhotic patient. In this study published, where 145 patients were assessed, grade 1 was diagnosed based on the West Haven criteria, and MHE was assessed based on the CFF and PHES score. They also studied the health-related quality of life and the Pittsburgh Sleep Quality Index. Overall proportion, out of 145, nearly 41% of these patients had covert HE, and when they found that the covert HE was associated with health-related quality of life as well as with decreased sleep based on the PSQI index. So how to assess a covert HE? It is the gold standard is paper pencil, that is the PHES score, which is gold standard. A score of less than 0.4 and a score of less than 0.6 has poor survival. Less than 0.4, it assesses for CHE with a high sensitivity and specificity. The RBANS, or the recurrent brain assessment, which is also a paper pencil method, it also assesses the covert HE, but the main drawback with these two methods is that it takes time, nearly 25 to 30 minutes. Another important methods are the computerized or the inhibitory control test, the CFF, and the encephal Stroop test. We'll study this encephal Stroop on detail, because this has been studied as far as the remote assessment is concerned. So how this Stroop smartphone application work? That in this patient, the patients, they are assessed for off state and on state. Off state gives a neutral stimuli, on state is a incongruent stimuli. In the first you have to identify the color, and once the color is identified, then the screen switches to another jumble. In the on state, the color of the words are identified, like green is written in red, but you have to opt for red. So the overall, the on time and off time are calculated. And it was seen that in patients who have covert HE, on time plus off time of more than 275 seconds is significant. The only issue is that it runs in 5 sets. Each set has around 10 different assessment, so it takes nearly 10 minutes. But this has been validated in various studies that it correlates with the diagnosis of CHE based on the PHES score. This has also been studied when patients were assessed for their driving simulation, and it was seen that a score of 242 was significantly associated with driving simulation crashes and illegal turns. Then there is a shortened version where they found that, published recently, that a shortened version, that is, it usually takes less than 1 minute, it detects covert HE within 1 minute, and what they found that this has a good correlation when they assessed with the complete assessment. Then another important aspect to study in cirrhotic patient is the cognitive impairment. This is just the number of apps that are available. In this study, what they found that the number of apps which were available for cognitive impairment is around more than 109, out of which these 25 were assessed. But what we can see that most of these apps, they don't have any reliability for the normative data. They have less reliability. There is no validity. And most of these apps, they are not even connected with a caregiver provider. So it is just like a score with no actual output as far as the patient's assessment is concerned. And as of now, the Alzheimer's Disease Association, they still consider that self-administered zero cognitive examination is the best instrument tool for assessment of the mild cognitive impairment. Another assessment for CHE is the animal naming test, which was published in Hepatology in 2017, where the animal names were shown, and anything more than 15, that is the right estimation of 15 animal names, was found to have correlate with that patient does not have encephalopathy. But the important aspect to consider in this finding is that the covert HE patient, they might not have impairment of the verbal. There is an impairment of the verbal fluency. So just naming one animal name might not be as much relevant as far as the diagnosis is concerned. So as the treatment, the lactulose has been compared with no treatment, and in most of the psychometric analysis, it was seen that lactulose has fared better as compared to the non-lactulose regime. Same with rifaximin, where randomized control trials have assessed the driving simulation, cognitive impairment, and the sickness profile, and they have seen that patients' overall quality of life improves with rifaximin. And same with the LOLA also has been seen in various RCTs, that psychometric analysis assessment for CHE, and they have seen that LOLA improves as compared to lactulose or placebo. Now, going ahead with the remote monitoring or wearables, that how self-management could be improved with remote monitoring. So this publication, which showed that the number of publications for cirrhosis, which are actually taking care of the remote monitoring or mobile health, is least as compared to depression, addiction, cancer, or heart failure. And what the authors, they want to comment that there is a huge scope as far as the overall management with the remote monitoring is concerned, like the sleep disturbance, cognitive changes, oxygen saturation change. There is a heart rate change which may be affected in infection, the activity level scale which might change as far as the frailty and HE is concerned, the ascites and heart failure. But there are challenges. The challenges and recommendation for a successful implementation, as was stated by the multidisciplinary NIH Big Data Workshop, they said that there should be a clearly defined problem and a disease state. There should be an integrated system of healthcare delivery, technology support and services, personalized experience, enhanced end-user experience, aligned payment, and clinical and stakeholder support. And they said that the 3 V's are most important. That is the verification of the instrument or the data that is generated. There should be a proper analytical validation of the huge amount of raw data that is generated, and there should be some meaningful clinical validation. So these parameters were assessed in the remote monitoring in cirrhosis, like in the Patient Buddy app, which was published in 2017 by the Jasmohan Bajaj Group, where they studied the impact of 30-day readmission, out of which the total and HE-related admissions were monitored, and there were 40 patients and 40 caregivers. They found that 17 patients were readmitted in 30 days, but none of these patients were admitted for HE. 8 potential HE-related readmissions could be prevented because the app generated some alert which resulted into early intervention. And most of these enrolled patients and caregivers were responding favorably. The second study that I could find was the feasibility study, where a smartphone app-based facilitating the outpatient ascites management. In these, patients were given a Bluetooth-enabled weight scale, and 30-day readmission for ascites control or uncontrolled ascites was assessed. Any change in the weighing scale of more than 5 pounds up or below, more than increase of 5 pounds or decrease, and that was alerted to the patient as well as the caregivers. And it was found that nearly 52% of these patients were triggered by weight loss and 48% were triggered by weight gain. 17 readmissions occurred, but only 4 related to ascites. And they found that many of these patients, they wanted to extend their participation beyond 30 days. Then another important variables, which is very much now in common use, is the sleep tracking devices. So sleep tracking device, this is in the sleep study. This study was not performed in the cirrhotic patient, but there is a large study which is published for the cirrhotic patients, which I'll explain later. So in this study, the performance of the sleep tracking device along with their actigraph. Actigraph is the activity graph that the app generates. Of these 7 assessed, these were the 7 commonly or the commercially available the wristbands which are available. Out of these, 4 are wearable and 3 were unwearable. And what they found that the gold standard was the plethysmography. So what they found that there is a promising performance for tracking of sleep and wake. But in this study, these apps, they only studied 2 parameters, that is whether patient is sleeping or is awake. In the Whoop functionality, which is now versioned into a Whoop 3.0, where the actigraph was compared in the auto and the manual mode, and this has this thing. One is the 2-stage, that is sleep and wake, and one is the 4-stage, that is it assesses the awake state, light sleep, deep sleep, and REM sleep. And this also correlated pretty much well with the plethysmography. For this, in the cirrhosis patient, for covert HE, the wearable technology was assessed in 25 patients of extending up to 6 months with 2,892 nights. Overall sleep data was assessed. They found that 66.3% of these patients, they had steady adherence. Patients with CHV were consistently worse sleep and reduction in rapid eye movement. The reduction in the REM sleep was seen in CHE patient, and those in the restorative phase. And based on this, they found a CHE score, which is based on the albumin, bilirubin, rapid eye movement, and the sleep disturbance and sleep consistency. So to summarize, the cognitive impairment is a critical component, and it is a part of the cirrhosis patient which needs care, just like the Alzheimer's disease, that is early to diagnose and long-term treatment. Because continuous decline in the in the performance of cognitive assessment in encephalopathy will be there as patient will move from covert to overt. And this is the main factor that why caregiver support and social support is important. There is no single test as far as CHE diagnosis is concerned, but Stroop test has fared better in many clinical applicability. Post-COVID, this study was published from the Canadian Dr. Punita Tandon's group, where they found that patients' interest with video consultation and online personalized care has improved in the post-COVID era. But the acceptance for any app-based treatment would be based on the social demographic factor, and what they in this study found that the initial acceptance may be high, but they might not be willing to continue it for long-term basis. Remote monitoring is a potential to understand relationship between the intra-individual cognitive and various outcomes of encephalopathy for targeted intervention. And there is a huge scope as far as the dry lead portable EEG is concerned, evoked potential response and gait analysis by this Moticon insole system. In this, the footwear sole, it is having different gadgets, and the way the patient walks or gait, that generates raw data which has been seen to correlate with various neurocognitive impairment. Then another important aspect for the self-management includes the nursing care, where the Lever Hope Nursing Project has identified that early identification of complication, management of nutrition, and specific instruction as far as the outpatient and inpatient is concerned, and is very important. Then telemedicine and liver disease care gives a unique opportunity to deliver care remotely, easy adaptability, high patient rate acceptability, but yes, reduced face-to-face assessment will remain a challenge always. And with this, I would like to conclude that how a mobile health platform for cognitive impairment in cirrhosis will be, could be managed, that the actively collected app-based data or any wearable device, a huge big data would be generated, but a proper analytical verification and a clinical validity is required before any meaningful self-management care or instruction could be provided to the patient or his caregiver. And this is one letter to editor by Dr. Jas Bajaj, where they found that out of 130 30 physicians or liver disease care providers, that is the doctors who are practicing hepatology, they found that they offer screening to covert HE in nearly around 50 to 60% only. The main reason for not offering the screening for a covert HE is lack of time or lack of consensus or probably shortage of staff. But most of us think that overt and covert HE may actually impair our driving skill. So is it medically correct if CHE is diagnosed or missed for diagnosis?